Okay, thank you so much for Chairperson's nice introduction. I will follow Marina's presentation. Actually, the injection vascular accident are far less, is underreported actually. So this reason why, although we are here to share our thoughts, actually we try to reduce the rate of the vascular accident and also improve the emergency management. So, so many feeder complications are technique related and fortunately fixable. However, when it comes to patient safety, prevention is always the best policy in medical practice. So today I would like to focus on strategy of avoiding vascular accident. So here's a conflict interest disclosure. I have no such conflict interest here in my presentation, but the number of the vessel in the face is far greater than we saw before. So it is simply impossible to identify and name all of them. So how can we enhance the injection safety to reduce the risk of the vascular accident? Pain actually is one of the key indicators to consider. So while the absence of the pain isn't a reliable sign of safety, pain is often one of the first symptoms of the vascular accidents. So in my opinion, feeder containing lidocaine can mask these warning signs, potentially increasing the risk associated with vascular accident. So blanching is another early warning sign, but if it is caused by lidocaine with epinephrine, it can hide the signs of vascular injury. So that's why I don't use the numbing cream before injection. So in year 2021, Dr. Ford Nahai invited me to write a commentary for the Aesthetic Surgery Journal. And while research on anatomy and imaging has grown significantly, my 5 key tips remain essential as a practical guide to safeguard both you and your patient. So having a solid understanding of anatomy is something we should always keep in mind during injection. So teaching facial anatomy with a focus on precisely identifying the topographic location of nearby vasculature has been a popular approach for more than a decade. So I believe there's no injection sites that are completely safe or entirely risk-free. So in my opinion, try to point out the exact location of the vessels in any area doesn't really make sense. So for example, you might assume that there's no vessels along the midline, as shown in the image on the right. However, in this case, you need to be aware of at least 5 high-risk areas where blood vessel cross, as seen in the patient on the left. So in this case, the needle stuck a vessel at the median lingual foramen. Although extremely rare, it sadly resulted in tongue necrosis and deviation. So the authors strongly recommend using a microcannula to minimize the risk of hitting these unusual anatomic variants. So what seems more reliable to me is predict the depth of the vessel. Dr. Wong Lee, also on the stage, from South Korea, found that in 70% of the patient, the facial arteries were located medial to the nasolabial fold. Thankfully, only 4% of the patient had facial artery beneath the muscle. So this highlights a relatively safe area under this muscle in this case, that in what typically considered a high-risk zone. So doctors can safely inject deep down to the bone in the middle of the nasolabial fold. And this not only avoid blood vessel, but also ensure the aesthetic outcome. So in my humble opinion, while traditional ultrasound can help identify the position and the depth of a larger vessel, it may not be completely reliable for detecting vessels of all sizes. So while ultrasound is helpful for identifying the main trunk of the visual vessel, so performing injection while using ultrasound sometimes can be very tricky. It might make it harder to fully concentrate on injection technique, which are crucial for avoiding a potential risk. So thanks goodness for the fingertip ultrasound technique recently introduced by Dr. Benjamin Asher at International Congress And this innovative approach aimed to make dermal filler treatment safer and more precise. So with this method, ultrasound probe are placed directly on the practitioner's fingertips, allowing real-time visualization of facial anatomy during injection. So it is a smart way to reduce the risk of the vascular complication and improve accuracy. So ultrasound probes are attached to the fingertips of the non-dominant hand, usually the left, for the right-handed practitioner. And the probe can be covered either a sterile or non-sterile glove to ensure hygiene while still providing clear imaging. So many experienced injectors also believe that deep bone injection are safe. They often place fillers subperiosteally to achieve precise, consistent result, whether for a lifting effect or stable non-migratory augmentation. Dr. Tatiana Pavizic stated that the subperiosteal injection with needles was not possible. In a study, needles injected green dye, which travel throughout the muscular layer. This suggests that when needles are used for subperiosteal approach, actually contacting the bone causes the product that will go uncontrollably to the more superficial muscular layer. And Dr. Greg Goodman pointed out that performing a subperiosteal injection with a needle is neither safe nor feasible, and the height of the needle's bevel, combined with the pressure difference between the bone's resistance and the pierced vessel, can cause a bolus to be delivered primarily into the vessel, and as it's offered the least resistance, so that the filler will go to the least resistant area, which is the vessel. So however, using medical cannula actually might not be as safe as we once thought before. And the report from China actually that about 90% of the patients who experienced vascular accident actually, especially during the injection with microcannula. I think that because of the popularity of microcannula injection is getting more and more common. And also cannula not only become less sharp than needle when the size exceeds 22 gauge. So it makes 10T and 22 gauge cannula safer option compared to 25 gauge cannula. So I also once did a stupid thing using 25 gauge microcannula on my wife, and the blood was from my wife. So that's why that in my practice now, I almost only use 22 gauge microcannula. So a report says that doing a quick aspiration that before injection can help reduce risk. It suggests that to keep it under 2 seconds as long as the product and the needle are a good match. However, our friend Dr. Moon from South Korea and Dr. Greg Goodman from Melbourne had advised that aspiration isn't reliable and shouldn't be used as a safety measure. Greg explained that during the aspiration, the pressure probably caused the blood vessel wall to collapse. This blocked the opening and caused a false negative result, and if the needle or cannula is inside the vessel. And also my friend Dr. Steve Cohen from San Diego said that nothing in medicine is perfect or completely risk-free. So a careful injection technique actually is very essential. So when we focus on solely on aspiration, we overlook the essential injection technique that protect both your patient and you. So this includes maintaining continuous moving while injecting and using a slow injection speed, allowing low extrusion force, injecting smaller volume, and also have a complete understanding of the safer injection plan based on the vascular anatomy. So although it's a topic opening for debate, Greg suggests that keeping the needle or microcannula moving during injection help reduce the risk of the injecting product into a vessel, so enhancing safety. So let me show how I do it safely. So when using microcannula for injection, I usually first advance it slightly beyond the injection area, usually 0.5 to 1 centimeter, and then pull it back the same distance before starting the injection. So I injecting slowly while moving the microcannula in a gentle back and forth motion. And actually the technique not only ensure precise delivery, but also help minimize the impact of backflow from the cannula tip during the injection. So my conclusions are, Familiar with the anatomic structure in danger zone is essential, but anatomy alone cannot guarantee safety. So a safer level to avoid vascular accident is proving to be more reliable than focusing solely on safer space. And using microcannula and redrawing before inspiration is no longer sufficient on its own. And good injection techniques are far more important than we once thought before. So always redraw the cannula, keep it moving during injection, and deposit small aliquot slow. And additionally, advancement like ultrasound-guided technique are valuable. So real-time visualization finally probably will enhance ejection safety. Thank you so much for your attention. Thank you.